We're into the elbow now. The poor elbow. It's gotten neglected at this course. We have tried as hard as we can to hit you with as much information as possible. But the elbow is an easy joint. It's a hinge joint. So not a lot goes wrong with it, fortunately. The coronal is your view for collaterals. The most important collaterals are the anterior bundle of MCL, the lateral ulnar collateral ligament, or LUCL, the proper LCL. I start my assessment by looking at the arrangement and conformity of the elbow. Now, in the elbow, more than any other joint except the hip, the shape of the two bones matters most. The reason is tight capsule, no room for error. So flat, irregular, small bodies, small subchondral spurs, decreased range of motion. That's called sloppy hinge syndrome. Coronal view is also your view for common flexor, common extensor. Axial. As with most parts of the body, masses, bodies, entrapment neuropathy at the level of the cubital tunnel, the radial tunnel, the pronator tunnel, the anterior interosseous space. It's also your view for valgus extension overload to see if there is arthritis in the olecranon fossa, the first sign of valgus extension overload. It's a view for the annular or accessory annular ligament, which I routinely ignore. Sagittal. It's your best view for radial fractures, to look at the capitellum, to look for the dreaded Osborne collateral lesion, which is the elbow equivalent of the Hill-Sachs lesion, indicating a dislocation of the elbow. It allows you to pick up the terrible triad, which we'll discuss in a few moments, which includes coronoid process fracture, along with lateral ulnar collateral ligament tear. It's also your best view for long structures, biceps brachii, triceps brachii, and it's a supplementary view for dislocation. Okay, let's have a look at our first case. So in osteo, sagittal, sagittal, sagittal. Routine elbow, coronal, coronal, coronal. The elbow consists of 2 grooves and 3 bumps. There are the 2 grooves. Trochlear groove, trochlear capitellar groove, capitellum, trochlear capitellar bump, capitellum, trochlear capitellar bump, trochlea. Apologize. 2 flat. The radius a little too lateral. An erosion penetrating. Chondromalacia. Things aren't lined up quite right, and the grooves are too shallow. Sloppy hinge syndrome. So now we've got extensive radiocapitellar malacia. What should we do now? Check for a body. How are we going to do that? Axial. Let's do it. Where do the bodies go? When you lie down on your back, they go in the back. Olecranon fossa. Let's check it out. Any bodies in the back? No. Athlete. Now, in an old geezer like me, it might not matter that the medial collateral ligament has been stripped from the sublime tubercle of the ulna. But in an 18-year-old with arthritis at 18 years of age, if he's an overhead athlete, matters. You're going to see some better examples of this. So he's got a stripping, peel, tear of the UCL. But I'm showing it for sloppy hinge and radiocapitellar malacia with alteration and alignment and conformity of the elbow which gives no quarter because the elbow capsule so small, so tight, things have to fit just right. Next. 18-year-old complaining of elbow pain since a dislocation after wrestling. Assessed for loose body or UCL tear. So I'll start a complex case like this, coronally. Let's put them all up. Give you a second. This one's a little more complex. So typically, in most dislocations, it is a posterolateral force. So a very common mechanism for dislocation is a fall on an outstretched hand. Your hand strikes the ground like this. So axial load with a little bit of varus impaction. Sometimes it can be valgus, but more commonly varus. Your elbow's like this. Now what if you're on the ground and you're getting up, and somebody comes along and boom, they roll over your elbow. Now you've got a massive dislocation with a varus event. The defection, the disruption, the loss of stability almost always begins lateral and goes medial. So when you're grading these, you're probably going to see lateral injuries isolated or first, and then in higher grade ones, medial, and even higher grade ones, not just the anteromedial, but the entire medial. And that consists of the anterior bundle, main bundle, the transverse bundle, and the posterior bundle. So let's have a look. So what's the terrible triad of elbow dislocation? It is a lateral collateral ligament tear, a coronoid process fracture, and a radial head injury. Let's see, do we have a coronoid process fracture? Let's check out the sagittal. We don't. Do we have a lateral collateral ligament injury? Okay. So the lateral collateral ligament consists of an anterior proper collateral ligament. Let's go anterior. There it is. Here's our anterior proper collateral ligament here. Now let's follow it backwards, see what happens to it. We've lost it. And then all the way in the back, right there, coming off in this spot, and weaving its way behind the radius is the lateral ulnar collateral ligament, or LUCL. So both of those are important. The LUCL, more important of the two. Whoops. So let's see our LUCL on our 1.5 millimeter image. There it is. It's supposed to come off over here. It should have a funnel shape. It comes off like this. Whoops. Comes off like this, like a little funnel in the back, and then wraps around, goes behind the radius, and inserts on the Christus supernatoris. So pretend this is going behind the radius right here of the ulna. Now let's take it away. Our LUCL is flopped into the joint. So lateral, ulnar collateral ligament rupture. We said this process proceeds in severity from lateral to medial. So let's check out the medial. Do we have an MCL injury? You bet we do. We've ruptured both ends of the MCL. Proximal end, distal end. The main bundle of the MCL is the anterior bundle. There should be no space between the distal end and the tubercle. There's plenty of space and the rest of the ligament is destroyed. Can't fix that ligament. Has to be grafted. So usually take a piece of tendon and fold it over on itself and do what's called a docking procedure. Okay, we're not done yet. We already said 2 lateral collateral ligament parts gone. The 2 most important, proper anterior, lucal posterior. On the medial side, most important, MCL, anterior MCL, torn, pulverized, destroyed. Let's go back, posteriorly. Sorry, that's anterior. Let's go backwards. There should be a band-like structure right here. I'm going to show it to you axially. Let's take a look at it axially. Let's look at the other components of the medial collateral ligament. They form the floor and the roof of the cubital tunnel. Here's the transverse ligament right here. I'm going to draw on it. Floor of the tunnel. So it's actually swollen but present. And let's look at the roof of the tunnel. Roof of the tunnel, right here. Posterior band of UCL, transverse bundle of UCL. So swollen, injured, present. What's in between this little dot? Ulnar nerve. What's this thin, arcuate, laminar area of low signal? Osborn's fascia. So 2 separate structures, analogous to the medial retinaculum and the MPFL in the knee. Osborn's fascia superficial, posterior bundle UCL, roof of the cubital tunnel, transverse bundle, sometimes having 2 heads, floor of the cubital tunnel. Are we done? No, we're not done yet. Checklist. How are our nerves? We've had a massive injury. Let's check out the ulnar nerve. There it is. It is not subluxed. It is not bright on T2. It is not interrupted. We have a muscular portion of the nerve. We have a retroepicondylar portion of the nerve. We have a supraepicondylar portion of the nerve, and that is slightly edematous. Look at the difference in signal of that and that. On a T2, the nerve should be dark gray, not light gray. I'm not talking spur, stir, special, spare. I'm talking T2. So the nerve up high at the top of the condyle has been injured, but not transected. We done yet? Now we got more nerves. We have the radial tunnel. Hematoma? No. Do we see the nerve? Yes. The deep interosseous posterior nerve is right there. Little muscle injury, nerve okay. What's another nerve we'd be interested in? The median nerve. It's not in the neighborhood of the injury. What about the terrible triad? We said we want to check the coronoid. Let's do it again. It's okay. The coronoid didn't give way, for if it does, now there's nothing to hold the humerus in place anymore. The patient's even more unstable. The deeper the fracture, the worse the instability. So you can grade the violence of the event by how far down the base of the coronoid the fracture is. So why didn't it break? Because the muscle and capsule broke instead. That's the brachialis. One of its attachments, the deep attachment, goes to the coronoid. No longer attached. It's off, brachialis tear. Capsule also attaches here. Capsular tear. That's why fluid is leaking into the anterior compartment. So we've got an anterior capsular disruption. Are we done yet? Not really. Let's turn to the short axis view. Here, by the way, is a better view of your muscular injury. We're still going right. We're marching right down the checklist. What's next? Well, big tendons. Let's check out the biceps and triceps. We've already established there is a deep brachialis tear, superficial brachialis intact more distally. About the biceps. Find it right here. That's the biceps, that's the brachialis. Let's follow the biceps to the radial tuberosity. It's normal. Triceps. Triceps has a superficial lateral head, lateral, long head, medial, and a medial head, deep. The medial head has no tendon. Medial head, long and lateral heads, normal. Small microtrabecular injury in the back of the elbow. Are we done yet? Nope, we're not done yet. We said the elbow is a fortress. It is guarded by the now failed MCL. It was guarded by the now failed LCL. Anterior, the proper. It's gone. Posterior, the lucal. Sorry, that's anterior. Anterior, it's gone. Posterior, the lucal. Probably better seen here, it's off. And because there's a piece of bone off with it, hard to appreciate, there's some swelling in the underlying bone. But what's next? What's the next part of the fortress? Common extensor and common flexor. Here's our common flexor. Swollen, bent, but not broken. Origin, intact. Ooh, look at that nasty MCL. Never going to be able to repair that. Have to graft it. Let's go to the common extensor. Not so good. Common extensor, off. So common extensor tear, LCL tear, lucal tear, anterior bundle MCL tear, brachialis tear, capsular tear, no coronoid fracture, fusion or hemarthrosis, complex instability, high-grade dislocation, patient at risk for complex recurrent instability without a surgical procedure. 21-year-old, male, with a football injury. Let's go coronal. Should be getting pretty sophisticated now with these coronal views. Let's grab one sagittal. Now when the elbow dislocates, frequently the humerus is slammed forward. It may jut over the coronoid ligament. The back of the humerus will demonstrate an impaction injury. That is known as the Osborne collateral injury. You now know this elbow has dislocated. What about our coronoid process? So important, intact. How about our brachialis insertion? This time, intact, but the brachialis muscle tore. The capsule tore. So it tore up higher. Very muscular person. Triceps, good. Biceps, normal. Brachialis, established. Let's go to the coronal. Let's go anterior. The anterior RCL, the proper RCL present, now absent. So an incomplete, full thickness, proximal, proper, lateral collateral ligament tear. Let's go find the posterior lateral ulnar collateral ligament. It should have a funnel-shaped origin right here, flush on the bone. It's over here. There's our funnel. It's coming around to go to the Christus supinatoris of the ulna. Well, there it is, and there it's off. So it is detached from the posterolateral humerus. It's usually one of the first things to go. Do we have a radial head fracture? Part of the terrible triad? Nope, we don't. There's the detached lucal seen in the sagittal projection. Shall we go to the medial compartment? Let's check it out. The MCL is ruptured proximally. While we're in the neighborhood, let's check out the common flexor. It's toast. It's pulverized. Let's check out the common flexor. Let's check out the common extensor. It's off with some blood in between. Wow. Common flexor off, common extensor off. What's that slit-like thing in the joint? Not sure. Could be cartilage, could be some coagulated blood. Let's check out the rest of the UCL axially, which forms the floor and roof of the cubital tunnel. So medial side where you don't have the radius. So you can get oriented very quickly. Give you 10 seconds to decide. Okay. The answer is gone. Look at the ulnar nerve. It's not behind the condyle. The roof of the cubital tunnel was this. It's gone. The floor of the cubital tunnel, which should be a thick linear structure, you saw it in the last case, it's now a little curved structure, curved on itself. It's gone. So the transverse and posterior bundle, the floor and roof of the cubital tunnel are gone. No more tunnel. So where does the ulnar nerve go? It floats out. It's a T2. Sorry, it's a PD. Do we have a T2? It'd be lovely if we did, because we sure want to know if that nerve is injured. I suspect it is, though, because it's been pulled completely out of its space. More importantly, is it transected? Let's put a little marker on it, see if we can follow it. There's the nerve right here, and that is a T2, and that's your nerve. Your nerve is clearly injured. Look at how irregular it is right there. So it's a partial tear of the ulnar nerve. See it right here? Nerve, swollen nerve, partially torn nerve. Ooh, that's nasty. What about the radial tunnel? Well, he's got no symptoms there, but there is a little swelling. There's no hematoma. That's the best you're going to do. Where's the interosseous posterior portion or motor division of the radial nerve? Right there. And where is the median nerve? Right there. What about the artery and vein? Do we have a dissection? No. So, conclusion. Grade 3B, don't have to worry about the grade, or high grade elbow dislocation with anterior capsular disruption, Osborn collateral lesion, tear of the brachialis, rupture of all three components of the UCL, anterior, transverse, and posterior, rupture of the lucal at its origin, tear of the LCL, no radial head fracture, no coronoid fracture, common extensor tear, common flexor origin tear, end. And that concludes our course. I want to thank our videographers and sound team, John and Colin. Especially want to thank my wonderful friends and team and colleagues who have supported me. Alex, Chris, Jordan, Paul, Dan, and Troy, who are at home. I want to thank all of you for giving me the opportunity to do what I love. Every day I get up and put one foot in front of the other on the floor and think, what am I going to do today to make a difference? and it's awfully kind of you to let me do what I love to do in front of you. Thanks so much for your feedback, for not being afraid to bring things up, because I learn from you just as you learn from me. And especially want to thank my wife and children who've allowed me to live this life for the last 35 years, and to the hotel staff. Have a safe trip home. Thank you.